अगर कोई कैनाल प्रेजेंट है एंटीरियर एब्डोमिनल वॉल में, will it be providing strength to the wall or it will be creating a weakening in the wall? It will be creating a weakening in the wall because a hole is formed in the wall. So that means it is vulnerable to the intestinal contents can be herniated through the canal. So there should be certain mechanisms, there should be certain natural mechanisms that why the hernia is not occurring naturally. So that is also we are going to discuss. So where the inguinal canal is situated, it is in the anterior abdominal wall. What are the layers in the anterior abdominal wall? Because when we are thinking of the boundaries of the canal, we should know the muscles which are forming the anterior abdominal wall. So what are the layers in the anterior abdominal wall? From outer to inner, just raise your hands who wants to answer. What are the layers? Anybody? Skin, Camper's fascia, Carpa's fascia, both are the superficial fascia. Then muscle, external oblique, internal oblique, transversus abdominis. Then inside the transversus, there is one more fascia. That is fascia transversalis. Then comes the extraperitoneal connective tissue, and inside the extraperitoneal connective tissue there is peritoneum. So if these are the layers inside which a canal is formed, some of the layers will be forming the anterior wall and some of the layers will be forming the posterior wall of the canal. We have to just revisit what are the layers which will be forming the anterior, and if we are saying it is a canal, then it will be having two ends which will be open. So the two ends are the deep ring and the superficial ring. These are the layers which are present. This is skin, this is superficial fascia, there is external oblique, internal oblique, transversus abdominis. Inside this there is fascia transversalis, this is extraperitoneal connective tissue is there. So first of all, just revisit the inguinal ligament, because there are certain structures, or I would say certain extensions of the inguinal ligament which are included in the floor of the inguinal canal, or they are located in the other boundaries also. So what is inguinal ligament? Exact definition of the inguinal ligament: it is the lower border of external oblique aponeurosis which is folded upon itself forming the inguinal ligament. So it is nothing. मुझे एक फिजियोथेरेपी का स्टूडेंट याद आता है. ही सेड वंस कि मैम, ligaments are the structures which connect bone to bone, or they are present at joints. Why there are ligaments in the thoracic cavity, in the abdominal cavity? So here the ligaments are formed by the thickening of the connective tissue. So here the connective tissue is the external oblique aponeurosis, whose lower end is folded to form the inguinal ligament, and she correctly answered that it extends from the anterior superior iliac spine to the pubic tubercle. So this is the inguinal ligament. It presents a grooved upper surface. Its length is around 12 to 14 centimeter in adults, but the length of the canal is around 4 centimeter. Its medial end presents three expansions, which you will be reading in the boundaries of the inguinal canal. So one must be familiar with these three extensions of the inguinal ligament. They are the lacunar ligament, the pectineal ligament of Cooper, and there is one more reflected part of the inguinal ligament. Actually, inguinal ligament, they are the fibers. The thickened fibers are present. Some of the fibers, they might be extending near to the nearby structures, and they are forming these three extensions: lacunar ligament, pectineal ligament, and the reflected part of the inguinal ligament. So this, lacunar ligament, it is a triangular shaped structure is formed, and its apex is attached to the pubic tubercle. Then pectineal ligament is some of the fibers from the lacunar ligament, they will be extended to the pectin lines, pectin pubis, so they will be forming the pectineal ligament. And the reflected, I will show you the pictures, the reflected part of the inguinal ligament is some of the fibers from inguinal ligament at its medial end. All these three extensions are present at the medial end. Where is the medial end? Medial end is at the pubic tubercle. So all these three extensions, they are present at the medial end. So some of the fibers at the medial end from the inguinal ligament, they will be passing upwards and medially towards the linea alba. So they will be forming the reflected part of the inguinal ligament. Now we will be seeing these structures one by one. Now here you can see this is the lacunar ligament. So some of the fibers which are attached at the pubic tubercle, they are going back and they are forming a triangular structure. So this is the lacunar ligament. Then some of if this is the pubic tubercle, there is pubic symphysis, pubic crest, and then you can see some of the fibers, they are going backwards from this extension. They will be forming the pectineal ligament of Cooper. So what is lacunar ligament? It is triangular in shape. Here you can see this is the lacunar ligament, this is the inguinal ligament. Its apex is formed by the pubic tubercle and its base is free and concave. So this is the base, this is the apex, and upper surface will form a part in the floor of the inguinal canal. So a triangular shaped structure is formed whose apex is at the pubic tubercle and some of the fibers, they are going upwards and medially. Then what is pectineal ligament? From the base of the lacunar ligament, some of the fibers are extending towards the pectin pubis. Pectin pubis is what? If you remember, there is a pectineal line on the this hip bone or the pubis part of the hip bone. So to the pectin pubis, it is extending, and up to where they are extending? Up to the iliopubic eminence. So these are the fibers which are extending from the base of the lacunar ligament to the pectin pubis up to the iliopubic eminence. So this is the lacunar ligament, this is the pectineal ligament. So then the third reflection or the third extension of the inguinal ligament is the reflected part of the inguinal ligament. You can see some of the fibers from inguinal ligament, they are going backwards and upwards and medially towards the linea alba. So they at the medial end, some fibers will pass upwards and medially, and they will join the linea alba. How they are related to the superficial inguinal ring? Because superficial inguinal ring, you can see this is the superficial inguinal ring which is present above and lateral to the pubic tubercle. So they are related to that. I'll come to the superficial inguinal ring. For the time being, what you have to remember is there are three extensions from the inguinal ligament. They are the lacunar ligament, the pectineal ligament, and the reflected part of the inguinal ligament. And they are related to which boundary of the inguinal canal? That they are related to the medial end, and inguinal canal की कौन सी boundary बना रहे हैं, that we will be seeing. Now I am coming to the inguinal canal. If it is a canal, it should be open at two ends, the lateral end and at the medial end. So its lateral end or the above end is known as the deep inguinal ring, and the end which is medial and lower, that is known as the superficial inguinal ring. The structure which is passing through the canal is the spermatic cord in the males. It is pulled up like this. This is the canal, this is the deep ring, and this is the superficial inguinal ring. Now this deep inguinal ring is situated 1.25 centimeter above the mid-inguinal point. What is mid-inguinal point? Midway between the pubic symphysis and the So if somebody says in a live patient, can you palpate the deep ring? You can palpate. Ring occlusion tests are done. So just you have to remember it is situated 1.25 centimeter just above the mid-inguinal point. This superficial inguinal ring is present above and lateral to the pubic tubercle. So this is the superficial ring. One more thing, we will be coming to that. Deep inguinal ring is formed in the fascia transversalis, and deep superficial ring is a hole or a gap in the external oblique aponeurosis. Because ultimately all these structures will be present in the layers of the anterior abdominal wall. So somewhere they are present. So what is an inguinal canal? It is a musculo-aponeurotic tunnel which extends from deep inguinal ring to superficial ring. It is directed downward, forward and medially, and it is present above and parallel to the medial half of the inguinal ligament. What is the length of inguinal ligament? 12 to 14 centimeter. The canal is around 4 centimeter in length, situated just above the medial part of the inguinal ligament. So, and it is extending from deep ring to the superficial ring. Fascia transversalis is deep, so that is why that ring is deep. External oblique, so that is superficial, so that is why the ring is superficial, lateral, medial, so length of the canal is 4 centimeter. The canal is narrower in females. In newborns, the canal is straight. It is not oblique. Deep ring and superficial ring, they are parallel, we can say. So it is in the straight line because the anterior abdominal muscles are not properly differentiated in the newborns. Then just a few words about the development so that you will be knowing why this canal is present. What happens is, where are the testes developed? Any idea? Are they developed in the scrotal region? No, they are developed in the abdomen and they have descended to the scrotum. So the path which they have followed during their descent is the inguinal canal. So that is why this canal is formed. They have developed in the abdomen, descended through the inguinal canal, and they have reached to the scrotum. And you know the reason why the testes are in the scrotum? Because a 3-degree lower temperature is required for sperm formation. So that is why so if testes are descending through the abdomen, they are going to the scrotum, can any structure survive without the blood supply and the nerve supply? No. So that means testicular artery, testicular vein, the nerves, everything has to go from the abdomen to the scrotum. So they are passing through the spermatic cord, which is the content of the inguinal canal in males. Ovaries have not descended to labia majors. So the content in the females is round ligament. So, and there is one more nerve, that is the ilioinguinal nerve. We will be coming to that, but the basic concept is the canal is broader, wider in males because testes have descended through that. So now just look at this. This structure is known as gubernaculum testis. It will be pulling the lower pole of the testis towards the scrotum. And when it has pulled the testis towards the scrotum, it will be pulling a fold of the peritoneum also along with it. This fold of peritoneum is known as processus vaginalis. You have to remember the name. The processus vaginalis is also pulled. You can see the pink structure. It is pulling the testis lower pole, and then it is attached. This gubernaculum is attached to the base of the scrotum, and it has pulled the testis downwards. If somebody knows when a baby is born, the pediatrician palpates the scrotum for the testis, whether they have descended or not, because the testis descends, they reach to the scrotum at the age of 9 months only. And sometimes this descent can be delayed also. So as soon as a baby is born, the scrotum is palpated for the testis. Then, so what is a gubernaculum? It is a condensation of the band of the mesoderm extending from lower pole to the developing gonad. And inguinal canal represents the passage of gubernaculum through the abdominal wall. So as the gubernaculum shortens, the testis will be descending. How they are, I'm not going into the detail because development you will be reading afterwards also. So at fourth month of no talking, at fourth month of intrauterine life, the testes appear in the iliac fossa. Just see, at seventh month they reach the deep inguinal ring. At eighth month they traverse the inguinal canal and finally reach scrotum at or slightly after birth. So at seventh month they are at the deep ring. In the eighth month they descend through the canal and then they reach, and processus vaginalis is a closed vaginal sac which helps the testis. It will also be pulled down into the scrotum. Now coming to the inguinal canal, the gross anatomy. So what are the contents of the inguinal canal? Everybody should know. This is a very important question. Whole of the inguinal canal, it comes in the exams. Spermatic cord in males and round ligament of uterus in females, along with the ilioinguinal nerve in both males and females. So you have to remember spermatic cord and ilioinguinal nerve in males and round ligament of uterus along with the ilioinguinal nerve in females. So these are the contents. Now what are the boundaries of the canal? So if we see canal as a tube, it has got an inlet, an outlet, anterior and posterior walls, a roof and a floor. एक tube like structure को imagine करें. So there is a roof, there is a floor, there is anterior wall, there is posterior wall, there is a lateral end, there is a medial end. So what is the inlet for the inguinal canal? Deep inguinal ring. And what is the outlet? Superficial inguinal ring. And what is entering? What is passing through it? Spermatic cord and the ilioinguinal nerve. Remember one thing, ilioinguinal nerve does not enter through the deep ring. It pierces the internal oblique and then it enters into the canal. This you have to remember. Ilioinguinal nerve does not enter through the deep ring. Only the spermatic cord or the round ligament, they will be entering through the deep ring. Now inlet is formed by deep ring. What is deep ring? It is a oval or U-shaped opening. It lies in the fascia transversalis 1.25 centimeter above the mid-inguinal point, and it is bounded by a superior and an inferior crura. So you have to remember it is in the fascia transversalis. These are the relations of the deep ring. I am not going into their details, but just remember above there are arched fibers of transversus abdominis. In front and laterally there is internal oblique. Medially there is inferior epigastric artery, and there is something called as interfoveolar ligament. Not exactly as in the exams, but you have to remember it is in the fascia transversalis. Then outlet is formed by the superficial inguinal ring, and it is a triangular gap that was oval or U-shaped. This is triangular gap situated above and lateral to the pubic tubercle. There was one more opening which was situated below and medial to the pubic tubercle. If you remember, we differentiate the femoral and the inguinal ligament by seeing the neck of that herniated swelling. If it lies above and lateral to the pubic tubercle, it is inguinal hernia, and if it is through below and medial to the pubic tubercle, it will be femoral hernia. So just remember it is situated above and lateral to the pubic tubercle, and the structures passing through it will be the ilioinguinal nerve and spermatic cord or round ligament. So its margins are called crura. There are two crusts. There is one medial crust and one lateral crust. So medial crust is attached to the pubic symphysis, lateral crust is attached to the pubic tubercle. This is the triangular opening, and it is reinforced by the reflected part of the inguinal ligament and the inguinal ligament itself. Its medial crust is thinner, its lateral crust is stronger. If you remember, you can. So its measurements are this much. Base is formed by the pubic crest. There are intercrural fibers also. Medial crust is attached to symphysis pubis. Lateral is attached to the pubic tubercle. Now coming to the anterior wall of the inguinal canal. अब इसके लिए basic concept क्या है कि internal oblique is forming the anterior wall and the roof. There are certain arched fibers of the internal oblique which come in the anterior wall. They will be forming the roof of the canal, and some of the fibers will be going in the posterior wall also. So mainly the anterior wall is formed by the skin, superficial fascia and external oblique aponeurosis. This we can think of also because they are superficial skin, then there is superficial fascia, then there is external oblique aponeurosis. In the lateral 1/3 there are fleshy fibers of internal oblique. If you remember, some of the fibers of internal oblique were taking origin from the lateral 1/3 of the inguinal ligament also, so they will be coming in the anterior wall of the inguinal canal. So this way it is formed. Then the posterior wall, it is formed mainly by the fascia transversalis. So the posterior wall is formed by the fascia transversalis, but fascia transversalis is a very thin structure. As compared to the muscles, it is quite thin. So it is reinforced by, in the medial half, by the conjoint tendon in front of the fascia transversalis. So this is the conjoint tendon. What is conjoint tendon? From where it is coming? Internal oblique and transversus. Some of the fibers of internal oblique and transversus abdominis, they are forming a combined tendon which is attached to the pubic crest. You can see this, these are the fibers. So they will be forming, partially they will be reinforcing the posterior wall. In medial 1/4 there are certain fibers of reflected part of the inguinal ligament. Where are these fibers going? Reflected part of inguinal ligament. कहाँ से थे ये, कहाँ पर थे? They were situated at medial end and they were going towards the linea alba. So these are the reflected fibers of reflected part of the inguinal ligament which are present in the medial 1/4 of the posterior wall of inguinal canal. Anterior wall किसने बनाया? Skin, superficial fascia, एक्सटर्नल ओब्लिक एपोन्यूरोसिस. पोस्टीरियर वॉल किसने बनाया? फेशिया ट्रांसवर्सालिस. मीडियल हाफ में क्या है? कंजॉइंट टेंडन और रिफ्लेक्टेड पार्ट ऑफ द इंग्वाइनल लिगामेंट. कंजॉइंट टेंडन इज फॉर्म्ड बाय फाइबर्स ऑफ internal oblique and transversus abdominis which are attached to the pubic crest. So these are the fibers. Then roof and the floor. फ्लोर आई टोल्ड यू, कुछ भी भूल जाओ, इंग्विनल कैनाल किससे रिलेटेड है? इंग्विनल लिगामेंट से. सो फ्लोर इज फॉर्म्ड बाय द ग्रूव्ड अपर सरफेस ऑफ द इंग्विनल लिगामेंट एंड एट इट्स मीडियल एंड द लेक्यूनार लिगामेंट इज ऑल्सो प्रेजेंट. So inguinal ligament and the lacunar ligament at the medial end, they are forming the floor. This is the lacunar ligament. Then roof is formed by the arching fibers of the internal oblique and the transversus abdominis. So roof is formed like this. This is formed like this. ये canal तुमको 3D में समझ आ रहा है? There is a deep ring. Deep ring is situated in which layer? Fascia transversalis. And superficial ring is situated in which layer? External oblique aponeurosis. So that is a fascia transversalis is deep and external oblique aponeurosis is superficial. So from deep ring to the superficial ring, the is extending. I can make out the students are playing either with mobiles or doing whatever they to do. It is none of my concern, but if you are sitting, it is morning class 9 to 10, so pay attention, it will be your benefit, I guess. So then floor is formed by what? Inguinal ligament, and at the medial end it is reinforced by lacunar ligament. Then roof is formed by the arching fibers of the internal oblique and the transversus abdominis muscle. So this way this inguinal canal is formed. Now there is one triangle through which the direct inguinal hernia occurs. So you have to remember the boundaries of this triangle, and this triangle is known as the inguinal triangle of Hazelbach. ठीक है, ये inguinal triangle of Hazelbach हम क्यों पढ़ रहे हैं? Because direct inguinal hernia can occur through this location. In that, we will be seeing there are two types of inguinal hernia, indirect and so indirect will be through the inguinal canal. The herniated part will pass through the deep ring. It will come out through the superficial ring. In direct inguinal hernia, we are calling it as direct inguinal hernia. The structures won't pass through the deep ring, but they will come out through the superficial ring. A hernia is called inguinal hernia if the herniated contents are passing above and lateral to the pubic tubercle. That means they will come out through the superficial inguinal ring. But inguinal hernia can be direct, it can be indirect. It is indirect when it is going through the deep ring, coming out through the superficial ring, and it is direct when it is protruding through this Hazelbach triangle and then coming out through the superficial ring. So what are the boundaries of this triangle of Hazelbach? You can see this is which muscle? Rectus abdominis. This is the lateral border of rectus abdominis. This is the inferior epigastric artery. So two boundaries, laterally it is bounded by inferior epigastric artery, medially it is bounded by the lateral border of rectus abdominis, and it's below it is bounded by the inguinal ligament. This is known as the Hazelbach triangle, through which direct inguinal hernia, most of the time it occurs through this triangle of Hazelbach. So now what are the contents present in the spermatic cord? What are the contents present in the spermatic cord? Can we think of the contents? Because testes have descended, so spermatic cord is a connection between the abdomen and the testes. So what can be the structures? There is testicular artery, testicular vein. There is one duct coming out from the testis, vas deferens. So there is an artery to the vas deferens also. So vas deferens is the main content. Then there is artery to the vas deferens. There is cremasteric artery also. So these are the contents. So what are the components of the spermatic cord? Everyone should know. Just look at these. There is vas deferens, testicular artery and vein, testicular lymph vessels. There are autonomic nerves supplying the testis. Testis में somatic nerve नहीं हो सकते ना, and yesterday I told you T10 is the sympathetic supplier to the testis. So autonomic nerves, remains of the processus vaginalis. There is one genital branch of the genitofemoral nerve. It supplies the cremasteric muscle. There is one muscle that is called as cremasteric muscle. This cremasteric muscle is a U-shaped muscle. Its fibers are derived from the internal oblique and the transversus abdominis, and these U-shaped fibers are going to the scrotum. So if it is somewhere in the scrotum, then it has to be supplied also. So this genital branch of genitofemoral nerve, it supplies that. There is one cremasteric artery and there is one artery to the vas deferens. So these all are the contents present in the spermatic cord. You will be seeing it in the cadaver, in the dissection also. So what is vas deferens? It is a cord-like thick muscular structure. You will be having a class on testis and scrotum also. In that also you will. So it transports spermatozoa. It runs in the posterior part of spermatic cord and it hooks around the lateral side of the inferior epigastric artery. It is on the lateral side of the inferior epigastric artery. One thing you must remember, direct hernia is medial to the inferior epigastric artery, that is through the Hazelbach triangle, and this structure is lying lateral to the inferior epigastric artery. So inferior epigastric artery is the landmark which differentiates the direct and the this indirect hernia. So what is testicular? Next content is the testicular artery. It is a branch of the abdominal aorta. What is abdominal aorta? From where it has come? Descending thoracic aorta, it passes through the aortic opening of the diaphragm, T8, T10 and T12 level pe, then through the T12, and then it traverses the canal and it supplies the testis. Then there is Pampiniform plexus of veins. Testicular vein is formed by a, you must have uh, previously also read about this plexus, because this plexus is helpful in maintaining the temperature. There are a lot of veins through which the blood circulation takes place in the testis. The heat is dissipated through the scrotum also. So at the Pampiniform plexus there are around 16 veins. At the superficial ring they unite to form 4 veins. At deep ring, a single testicular vein is formed. So, at the testicular level, there are 16 veins. At the superficial ring, there are 4 veins. जब वो deep ring तक पहुंच गए हैं, then there is only one testicular vein. And one more thing, right testicular vein drains directly into the inferior vena cava, and left vein drains into the left renal vein. This question is asked, this will be repeated in further lectures also. Right is right, so right testicular vein directly goes to the inferior vena cava, and left one goes to the renal vein, and then it goes to inferior vena cava. Then there are lymphatic vessels, there are testicular lymphatic vessels, autonomic nerves, the sympathetic fibers from the renal or aortic sympathetic plexus. There is processus vaginalis, which is the fold of the peritoneum that has descended through it. There is cremasteric artery, artery to the vas deferens, and there is genital branch of the genitofemoral nerve. So this is the cremasteric artery, the artery to the vas deferens, and the genital branch of the genitofemoral nerve. Now, what are the layers which are which form the coverings of the wall of the spermatic cord? They are the internal spermatic fascia, cremasteric muscle and the fascia, and then there is external spermatic fascia. अब ये 3 नए टर्म्स आ गए, इनमें सिर्फ एक चीज ऐड हुई है, दैट इज स्पर्मेटिक. So there is external spermatic fascia. Can you think of the muscle which might be extending and forming this fascia? वहां पे भी 3 muscles थी, कौन कौन सी थी? External oblique, internal oblique, and the transversus abdominis. Along with that there was fascia transversalis. Now look at this picture. This is the external spermatic fascia. अच्छा, इसमें दूसरे साइड नहीं लिखा. It is this external spermatic fascia. It is the continuation of external oblique muscle. Then cremasteric muscle and fascia, they are derived from internal oblique muscle, and the internal spermatic fascia, it will be derived from the fascia transversalis. So transversus abdominis, and they have contributed to the cremasteric muscle and the fascia. Then next is the ilioinguinal nerve. So ilioinguinal nerve is coming from where? It is the ventral ramus of L1. There is one peculiarity of this nerve, that it is a mixed nerve at the beginning. Then it lies superficial to the spermatic cord. It leaves the canal through the superficial ring, but it does not pass through the deep ring. Then when it supplies the skin of the front of thigh and the external genitalia, it pierces the internal oblique muscle, and then it becomes cutaneous or sensory. So at the beginning it is a mixed nerve. Then when it pierces the internal oblique, it becomes cutaneous and a sensory nerve, and it supplies the skin on the front of thigh and anterior parts of the external genitalia. Does it pass through deep ring? No. It passes only through the superficial ring. Is it present in both males and females? Yes, it is a content in both males and females. So what is the structure which is present in females instead of the spermatic cord? That is the round ligament of the uterus, and the lymphatic vessels, they will be present in both males and females. Now what were the contents? What were the contents before coming to the defensive mechanism of the canal? What were the contents? Spermatic cord and the ilioinguinal nerve and round ligament in females. So inside the spermatic cord, what is present? Testicular artery and vein, vas deferens, artery to the vas deferens, genital branch of genitofemoral nerve, autonomic nerves, lymphatic vessels, cremasteric artery, then cremasteric muscle. So they were all, the cremasteric artery is present, and there was artery to the vas deferens. So that was the cremasteric artery is coming from the inferior epigastric artery. So it will be supplying this cremasteric muscle. Then there was processus vaginalis, which was a fold of peritoneum that was extending. Then, so now why defensive mechanisms are required in the inguinal canal? These defensive mechanisms are to prevent the hernia. हमने बोला कि there is a canal, there is a weakening in the anterior abdominal wall, which is created because of the developmental reasons, but it is present, it is there. So normal contents can be herniated through the inguinal canal. So to prevent herniation, there are certain defense mechanisms. Can you think of the defense mechanism? क्या क्या हो सकता है? there दो openings हैं, उनको मतलब कैसे prevent करें कि इसमें hernia ना हो इन दोनों openings के through? हाँ, क्या हो सकता है? इसमें लिखा हुआ है बहुत कुछ, बट जस्ट एक ट्यूब है और उसके मतलब दो एंड्स हैं, तो क्या हो सकता है? दोनों एंड्स को मजबूत कर दो. सो देयर शुड बी सर्टेन स्ट्रक्चर्स व्हिच माइट बी स्ट्रेंथनिंग द डीप रिंग एंड द सुपरफिशियल रिंग. देन द कैनाल इज ओब्लीक. तो वैसे ही ओब्लीक है, तो if it had been straight, तो hernia would have been easy. The canal was straight in the newborn. हाँ, so now what are the mechanisms? One is the obliquity of the canal. Deep and superficial ring are at different places. Where is the deep ring? In the fascia transversalis surface marking, very important because वो test करते हैं. 1.25 centimeter above the mid-inguinal point. And where is the superficial ring? In the external oblique and bony projection, bony landmark, pubic tubercle. All have to remember above and lateral to the pubic tubercle, because both the things can be palpated. You can palpate the pubic tubercle, you can make out the mid-inguinal point, and then you can feel for the deep ring. So they are present at different places. Then there is one mechanism which is known as flap valve mechanism. What is this flap valve? When there is raised intra-abdominal pressure, intra-abdominal pressure can be raised during defecation. Whenever there is difficult defecation, difficult micturition, or for other reasons, so then the posterior wall of the canal is pushed forwards and it comes in contact with the anterior wall, so the canal will be closed like a flap. So this is the flap valve mechanism. Now guarding mechanism is opposite to the deep ring. It is strengthened by the internal oblique muscle, and structure which is strengthening the superficial ring is the reflected part of the inguinal ligament. So if you remember, there was reflected part of the inguinal ligament at the medial end along with the conjoint tendon. So they were strengthening the superficial ring. So this way, these are the or bhi hai. There is one slit valve mechanism. What is slit valve? Due to approximation of two crura of the superficial inguinal ring. So it is known as slit valve mechanism. There is one shutter mechanism also. This shutter mechanism is because of the arched fibers of the transversus internal oblique and transversus abdominis. वो anterior wall में भी है, फिर roof में भी जा रहे हैं. So these arched fibers, so roof comes in contact with the floor. They act as the demi-sphincters. Then there is one thing which is known as ball valve mechanism. Have you heard of the cremasteric reflex? What is cremasteric reflex? It is because of the contraction of the cremasteric muscle. The testis, whenever the medial thigh is stroked, the testis will be pulled upwards and then they will be blocking the superficial inguinal ring. So this is the ball valve mechanism. So in increased intra-abdominal pressure, the cremasteric muscle, it will contract and pull the testis towards the superficial inguinal ring. So this will be closed. So what were the mechanisms? एक बार बता दो क्या क्या थे? Obliquity of the canal, flap wall mechanism, shutter mechanism, ball valve mechanism, then guarding mechanism. The two rings were guarded, the deep ring and the superficial ring. So they are prevented. The hernia is prevented. Slit valve, shutter, and the ball valve mechanism. Then the artery which is present, the cremasteric reflex, its afferent fibers will pass through the femoral branch of genitofemoral nerve, and efferent fibers will pass through the genital branch of the genitofemoral nerve. If you want to remember, you can remember. So whenever the medial thigh is stroked, this reflex occurs. Now coming to the applied aspects, they are the hernia. What are the two types of inguinal hernia? Direct and the indirect inguinal hernia. How will we differentiate between? हाँ, inferior epigastric artery से इन दोनों को differentiate कर लेंगे, और femoral hernia को inguinal से कैसे differentiate करेंगे? By the pubic tubercle, above and lateral if it is, then it is inguinal, and below and medial, then that is femoral. So hernia, what is hernia? Protrusion of a viscus through the wall containing it. वो जहाँ जो जिस wall में है, so it is an abnormal protrusion of a viscus or a part of viscus through a weak point in the wall of its containing cavity. So it is protruded like that. These are the different kinds of hernia. The epigastric hernia कहाँ होगा? Above the umbilicus, there was a region that was epigastrium. So epigastric hernia, umbilical hernia is at the umbilicus. There is congenital umbilical hernia also. At the time, तुमको पढ़ा रहे हैं शायद अभी, या अभी आएगा तुमको कि the intestine goes out when it is getting developed, and at the age of 10 weeks it comes backward. So suppose if the intestine which has gone outwards in the womb, if suppose it doesn't come backwards, then there will be congenital umbilical hernia, and that is very common. मैंने देखा हुआ है क्योंकि बेबी वो पूरा बाहर पेरिटोनियम दिखता है और intestine से ऐसे covered दिखता है. So that is congenital umbilical hernia if that persists. But otherwise there can be umbilical hernia because that is also weakening. So then there is inguinal hernia and the femoral hernia. There is one spigalian hernia, incisional hernia, ऐसा बहुत सारा. क्यों? What can be the etiology of the hernia? There is raised intra-abdominal pressure. Those people who carry heavy weights, usually they are more prone to develop the hernia. So there is straining of the abdominal muscle. So there must be the weakening of the anterior abdominal wall. So that leads to. So what are the contents? There is peritoneal diverticulum, the coverings of the sac, they will be present in that. Hernia can be reducible, irreducible, obstructed and strangulated. ये क्या है? Reducible, irreducible. When a patient is asked to cuff, तो क्या होगा? Intra-abdominal pressure raise होगा. Then the hernia can be produced, and then if it is pushed with, it can be pushed with the hand, या फिर when the patient is lying down, it goes automatically inside. That hernia is the reducible hernia. And when the condition becomes chronic or severe, then it becomes irreducible. चाहे lying down है, कफ नहीं भी कर रहा है. कई बार पेशेंट आके बोलता है जब मैं कफ करता हूँ तब मुझे यहाँ पे swelling फील होता है, जब लेट जाता हूँ तब एब्डोमेन ठीक रहता है. Then that is reducible. Then irreducible, it can be obstructed. Sometimes it gets obstructed, and strangulated is when there is like tightening or ischemia starts occurring. मतलब एक knot, strangulation हो गया उसकी neck का, so that becomes an emergency. That is the strangulated hernia. So it is that. Then inguinal hernia. So inguinal hernia is of two types: the indirect or oblique and direct. Indirect will occur through the deep ring. The contents will enter through the deep ring and they will come out through the super. Direct will occur through the Hazelback's triangle. You have to remember Hazelback's triangle, which is lateral to the inferior epigastric artery, which is medial to the inferior epigastric. Hasselback's triangle is medial, so direct will be medial to the epigastric inferior epigastric artery, and indirect will be lateral to the inferior epigastric artery. So it is oblique, indirect. Indirect is more common in the young population. If direct inguinal hernia, mostly it occurs in the old age when there occurs weakening of the anterior abdominal wall. फिर वो weakening जो है, that is irrespective of the ring. फिर वो deep ring है नहीं है उससे कोई मतलब नहीं है. Abdominal muscles are weakened, so they can be protruded through the Hasselback's triangle. In the young population, if the hernia is occurring, then it will follow the path which was created at the time of birth. So that will be in most. So canal of Nuck is also it is the thing which is there in the female, so it can be through that also. So it is mainly congenital. The contents will be entering through the deep ring. It will lie lateral to the inferior epigastric artery. Hernial sac may extend through the superficial inguinal ring, and when it is complete, it will reach to the scrotum. It might reach to the scrotum, it might not reach to the scrotum, because the whole path, spermatic cord, is still the scrotum. So if it is traversing along whole of the canal, then it might reach to the scrotum. So it can be complete, it can be incomplete. Now what are the coverings of the hernia? Peritoneum, extraperitoneal tissue, internal spermatic fascia, cremasteric fascia, external spermatic fascia, dartos muscle and the skin. Dartos muscle कौन है, कहाँ से आए है? Modification of? No, कल पढ़ा था हमने क्योंकि ये dartos. Camper's fascia and some fibers from the scar pass. So dark skin, dartos, then external spermatic is from the external oblique, then cremasteric muscle and fascia, internal and extraperitoneal, and the oblique inguinal hernia, it can be complete when the contents reach to the base of the scrotum. So then complete is known as the complete or vaginal hernia. Then hernia is limited to the inguinal canal itself. वो superficial ring से pass नहीं हो रहा है, then it is known as bubonocele. These are clinical terms. These are the applied aspects. If processus vaginalis is obliterated above the testis, but it remains patent in the proximal part, then the hernia is known as funicular. What is the difference between bubonocele and funicular hernia? It doesn't pass through the superficial inguinal ring. It has passed through the superficial inguinal ring but has not reached to the base of the scrotum. The processus vaginalis is obliterated. So then it is funicular hernia. So direct inguinal hernia, it occurs because of the weakness of the inguinal triangle of Hasselback. Then it arises medial to the inferior epigastric artery. It may extend through the superficial inguinal ring. Its coverings will be skin, superficial fascia, external oblique aponeurosis, conjoint tendon, fascia transversalis, and the peritoneum. Can you make out the difference in the coverings of indirect and the direct hernia? वहां पे स्पर्मेटिक फेशिया ये सब कवरिंग्स बना रहे थे, इन्हीं का एक्सटेंशन था, बट दोज वर द कवरिंग्स. नाउ these are the coverings which are the layers in the anterior abdominal wall. So they are the coverings in the direct hernia. So it can be a lateral direct or it can be a medial direct hernia. How can it be a lateral direct and a medial direct hernia? ये कौन सा ट्राइंगल है? Hasselback's ट्राइंगल है. होना कहाँ से है डायरेक्ट हर्निया? इसी Hasselback's ट्राइंगल से. What are the boundaries? This is what? Lateral border of rectus abdominis. This is what? Inferior epigastric artery. This is what? Inguinal ligament. So now this hernia can be medial direct, it can be lateral direct. कैसे होगा मीडियल डायरेक्ट, लेटरल डायरेक्ट? यहाँ पे ये कौन सी आर्टरी है? इंफीरियर एपिगैस्ट्रिक आर्टरी. यू कैन सी देयर इज वन मोर फोल्ड ऑफ this ligament is known as the medial umbilical ligament, and the ligament in the center is known as the median umbilical ligament. क्या दो लिगामेंट है ये? मीडियन अम्बिलिकल लिगामेंट एंड द मीडियल अम्बिलिकल लिगामेंट. So if the hernia is medial to this medial umbilical ligament, it will be medial direct. If it is lateral to this ligament, it will be the lateral direct. But both the direct type of hernia are medial to the inferior epigastric artery. If you want to remember, you can remember. If you don't want to remember, with time you will learn कि बहुत सारी चीजें हो रही है. एक कंसेप्ट बना लो, inferior epigastric artery के medial है तो डायरेक्ट हर्निया है. दैट कैन बी मीडियल डायरेक्ट और लेटरल डायरेक्ट. एंड इफ इट इज लेटरल टू द इंफीरियर एपिगैस्ट्रिक आर्टरी, इट विल बी द इनडायरेक्ट हर्निया. सो देयर कैन बी ओब्लिक हर्निया और द डायरेक्ट हर्निया. सो डायरेक्ट इज डायरेक्टेड ऑलमोस्ट स्ट्रेट फॉरवर्ड. एक बार ये वाले सारे जो डिफरेंसेस हैं, जस्ट गो थ्रू देम, देन I think the time is over. क्या क्या है इनडायरेक्ट और डायरेक्ट में डिफरेंसेस क्या है? इनडायरेक्ट कहाँ से एंटर हो रहा है? डीप इंग्वाइनल रिंग से. डायरेक्ट कहाँ से आ रहा है? थ्रू द ट्रायंगल ऑफ हेज़लबैक. देन इनडायरेक्ट अकर्स इन द young population because the path is always also is there, and then direct is bilateral and it appears in the old age. तो अगर कोई वेट बेयर कर रहा है ओल्ड एज में जाके, सो इट कैन प्रॉब्लम. दैट इज डायरेक्टली डाउनवर्ड फॉरवर्ड एंड मीडियली दिस इज ऑलमोस्ट स्ट्रेट फॉरवर्ड. सो दैट इज, इट इज डायरेक्ट. देन कॉज क्या है? कंजेनिटल ड्यू टू persistency vaginalis, or it can be the acquired weakness of the conjoint tendon. It is generally scrotal and that is rarely scrotal. If the hernia is scrotal, we are calling it as complete, and if it is not reaching to the base of the scrotum, then it is incomplete. So incomplete varieties हमने देखी, funicular hernia and the bubonocoel. So it can be there. बस एक और चीज which is very important clinically, that is the deep ring occlusion test. So how will you test the hernia, whether it is direct or indirect? One has to palpate the deep ring. Deep ring कहाँ है? पेशेंट को बोलेंगे खड़े हो जाओ, और मान लो हर्निया रिड्यूसिबल है तो हम उसको बोलेंगे यू स्टार्ट कफिंग. तो इंट्रा एब्डोमिनल प्रेशर विल बी रेज्ड. हमें क्या प्रेस करना है? डीप रिंग. कहाँ सिचुएटेड होती है डीप रिंग? 1.25 सेंटीमीटर अबव द मिड इंग्वाइनल रिंग. हमने उसको ऑक्लूड कर दिया है डीप रिंग को, तो कौन सी स्वेलिंग अपीयर नहीं होगी? कौन सा हर्निया अपीयर नहीं होगा? इफ इट इज इनडायरेक्ट. इफ इट इज डायरेक्ट इंग्वाइनल हर्निया, इट विल अपीयर. सो हाउ देन देयर कैन बी फीमोर. वो तो आके सीधे बोलेगा कि इंग्वाइनल रीजन में स्वेलिंग है. अब तुमको पता लगाना है वो फीमोरल है या इंग्विनल है. पहले तो ऐसे डिफरेंशिएट करोगे. फीमोरल कैसे पता करोगे फीमोरल है कि इंग्वाइनल है? हाँ, if the neck of the swelling is below and medial to the pubic tubercle, so that will be the femoral hernia. If the neck is above and lateral to the pubic tubercle, that is inguinal hernia. फिर inguinal में direct है या indirect? By the deep ring occlusion test. So this is done. There is hernioplasty, herniorrhaphy. Thank you.